Hello my dear students, in this session I shall be discussing a very important topic related to your endocrine pathology, that is multiple endocrine neoplasia syndromes. The objective is to describe the types and components of multiple endocrine neoplasia syndromes. So moving on to different subtypes, before we enlist these individual subtypes and know their components, it's important to know that these MEN syndromes are different from the sporadic tumors with respect to several aspects, that these are seen in younger individuals. They can be synchronous or metachronous in nature with respect to involvement of different endocrine organs, and also they tend to recur. Okay, so you need to know that these manifestations are related to multiple endocrine neoplasia syndromes. Apart from this, one characteristic feature is there will be invariably hyperplasia of associated cell of origin. For example, in case of medullary carcinoma of thyroid, even the uninvolved thyroid would show presence of C cell hyperplasia, and which will again give a clue that probably it is arising in the familial setting. Right? So now moving on to the individual subtypes, first is multiple endocrine neoplasia type 1, which is also called as Wermer syndrome. Remember these alternate names because question can be just based on these synonyms, right? So this is an important thing. What is the most common manifestation? So it is the primary hyperparathyroidism. And that can be due to a hyperplasia or it can be due to adenoma. What is the leading cause of mortality and morbidity in these patients is pancreatic neuroendocrine tumors. Now in this, majority of these tumors produce pancreatic polypeptides, okay, and they do not have these hormonal manifestations, but if they present as insulinoma or gastrinoma, then you have clinical manifestation as the hypoglycemia or peptic ulcer, okay. But these gastrinomas can also occur in the duodenum, that is extra pancreatic site. The most common site of gastrinoma which can manifest as Zollinger-Ellison syndrome, remember the site as duodenum. Now they can also have pituitary tumors involving the anterior pituitary in the form of pituitary adenoma, and most commonly they secrete prolactin, remember this. So they are prolactinomas. Now if you look at 3 P's here, so the MEN1 is associated with primary hyperparathyroidism, there is pancreatic neuroendocrine tumor, and there is pituitary adenoma. So this is 3 P's for MEN1 syndrome. You need to remember this. Now apart from 3 P's, there are some other things, that there is duodenal gastrinoma, and these patients can also have increased incidence of lipoma, thyroid tumors, adrenocortical tumors, etc. Okay, so the gene involved here is, remember this gene, menin gene. Okay, mutation involving the menin gene is responsible for MEN type 1 syndrome. Moving on to type 2 and its subtypes and components. So in type 2 we have got MEN2A and MEN2B, and then we have another specific subtype called as MEN4, which is different from 2A and 2B. So moving on to the components of MEN2A, remember that it is very important, it is 100% association with the medullary carcinoma of thyroid, very important. The other important tumor is pheochromocytoma, which can be bilateral as well as extra-adrenal, where we call it as paraganglioma in MEN2A. So remember it as pheochromocytoma. Then parathyroid hyperplasia. So the clinical symptoms can be related to medullary carcinoma of thyroid, then pheochromocytoma, and also in the form of the calcium stones which are seen in the kidney, as well as that gets deposited in the interstitium due to increased calcium levels because of parathyroid hyperplasia. But most important is 100% association with the medullary carcinoma of the thyroid. So what do you remember in genetics? Very, very important. Gain of function mutation involving the RET proto-oncogene. The germline mutation, remember it as gain of function mutation involving the RET, is very, very important. It is associated with MEN2A. Whereas loss of function is associated with, what is that condition called? Hirschsprung disease and intestinal aganglionosis. Very, very important, right? Loss of function. Whereas gain of function, germline, it is related to MEN2A. Now, how MEN2B differs from MEN2A? Because the components almost remains the same. What all will be there? One is the medullary carcinoma of thyroid will be present. And second, pheochromocytomas will also be present. And thirdly, instead of parathyroid hyperplasia, you have the involvement of the other organs, that is skin and mucous membrane, in the form of neuroma and ganglioneuroma, and also the marfanoid habitus. This is usually due to the point mutation involving the RET proto-oncogene, and it is different from the mutation which is seen in case of MEN2A. With respect to medullary carcinoma of thyroid in MEN2B, you need to remember that this is multifocal and also it is more aggressive, right, when compared to that of MEN2A. Now, because the most important cause of mortality in such patients, and they are going to develop for 100%, that is medullary carcinoma of thyroid, genetic screening is very, very important, right? Whenever you see the lesions which are related to the MEN2A or MEN2B, the RET gene screening is very, very important because it increases the susceptibility for other family members. So if you find out those carriers, it is important to do a prophylactic thyroidectomy to prevent the inevitable development of medullary carcinoma of thyroid that's going to be deadly in these patients. Whereas the role of genetic screening is minimal with respect to MEN1. Okay, and the other important point is, what is the other name for MEN2A? That can also be a question. What is the answer? Sippel syndrome. Remember this. Yes. With respect to MEN4, the components are similar to that what you see in case of MEN type 1. That is 3 Ps involving the pancreas, pituitary and parathyroid. But with respect to genetics, it differs from MEN1 in having cyclin dependent kinase inhibitor 1B. Right, so this is what you need to remember. It differs from MEN1. So that's all about the multiple endocrine neoplasias.